going to get going. So welcome everybody and good evening. Thank you all for joining us. For those of you I don't know, I'm Sandro Galea. I have the great privilege of being the Dean of the Boston University School of Public Health. I don't chair anything really. It's really great to have you all here for this event. Let me just say a couple of words about the school. For many of you, you know a lot about the school, but for those of you who are alumni, you may not have heard about some things happening in the school. We have a really outstanding School of Public Health. It has for decades done terrific things. It has graduated great alumni who have really gone on to change the world. We see our role as being a top-notch School of Public Health that does top-tier research, but is deeply invested in the real world, in real-world education and real-world doing. So this series, which is about making change happen, is directly in the middle of where we see ourselves, at the intersection of thought with action, where the scholarship that we generate really goes on to make a difference and to influence those who can make change happen on a global scale. At the school, for those of you who have not been there for a while, we have exciting new research initiatives. We have a lot of new faculty coming on board. We are transforming our educational program in many different ways, including a brand new MPH starting next year. And we're also investing in a number of initiatives to push forward on our engagement with activism, as defined as us being part of the social, political, economic, cultural changes that are needed to create the structures that make people healthy. For any of you who are alumni who do not get our regular mailings, we have a monthly regular mailing, we have a weekly regular mailing if you really want to know what's going on. And you can let Leslie or Amanda know and we'll make sure that you get that. But welcome, it's really great to have you all here. Let me just say a couple of words about this event. This is the Charles Donahue Frontiers in Public Health series. It exists thanks to the generosity of Charlie Donahue, who is one of our board members. Let me just say a few words about Charlie. So Charlie is he was the president and co-founder of Healthcare Value Management, which was New England's largest network of healthcare providers for self-funded PPOs. He did that for like 40 years, but he really has an amazing career. Charlie started his career as a Peace Corps volunteer with Malaysian Tuberculosis Control Program, and then he went to the Massachusetts Health Research Institute, Boston University Center for Health Planning, and the Health Planning Unit at the U.S. Department of Health and Human Services. What I actually think is amazing about that is that Charlie really has had a life in public health. I think he really has had the exposure to on-the-ground global public health, to systems, to government, to his own company. It really is, as far as I'm concerned, an exemplar of the kind of life in public health that we encourage all our students to envision for themselves. Charlie has been on our board for several years. It's been my great pleasure to work with him on our board since I came on in January. And the vision, I think, behind this series was really to bring together thinkers who are really engaging with the question of what are the key cutting-edge issues in health and how do we influence thinking about those cutting-edge issues? How do we inflect thinking so that we can actually make health better for populations? Charlie, thank you very much for making this happen. And now I'm going to ask Charlie to come up to say a few words. I have to give you my apologies that I have to leave because I am double booked and I have to go to another event. The good news is I'm not triple booked, but I didn't want to miss this event, so I really wanted to be here to welcome you all, and I'm going to hand over the podium to Charlie, and I'm going to quietly sneak out while Charlie then introduces the panel and hands it over to Professor Rosenblum. Charlie.
Welcome you all. Great to have you here tonight for our third in the series. Last year we looked at European health systems, which it's available on a DVD for people interested in how the conservative governments of Europe decided that they needed health insurance. There's a lot to be learned for people wanting to reform healthcare to learn that process. You have in front of you a little evaluation questions, and we've looking forward to your comments on our speakers, but we're also looking for ideas and speakers for future programs. Some of the speakers we've had have come from your suggestions, so we look forward to hearing from you on that. I just wanted to thank our speakers particularly, and also David for moderating this. I go back too far in my history of some of these issues. I first heard about Bob Masters 43 years ago when I had a board member, and he had the same board member, Ethel Lennox, a founding mother of the Upham's Corner Health Center, back when health centers just were getting started. At one time, 70% of the health centers in the United States were in Boston. It started here. But Ethel was unique. She would call Bob at 2 in the morning with an idea, but he was actually complimented because she also called at 2 o'clock in the morning Cardinal Cushing. Now, Ethel was Jewish, but he loved her. So she would call him up and say, "This is what we need to do." And the phone would ring at 2 in the morning, and he just would say, "Hello, Ethel," because no one else would dare. So this was a lady who trained Bob and myself, and then she would say to me, "Bob is doing this, you go talk to him." So we learned about each other through Ethel, and we're well trained. So we've had a wonderful chance to follow each other's careers. What we're trying to do in this series, and I want to just compliment the Dean for the speaker he already has brought before some of you, Jim O'Connell, who together with Bob are two people that I know personally from my work who are an inspiration because they've become social entrepreneurs. They've been out there in the health system dealing with issues and get hammered until they come up with ideas. They change the system. And Bob's been changing it for four generations. So I think hopefully some of you who will get out there, the young students and the new graduates, when you get frustrated, think of people like this who just never gave up. I just want to share with you one thing that touched me in reading the recent book by Jim O'Connell. As a young medical student, he was sent over to Rosie's place to work with some of the homeless people. And he walked in, and the nurses who run the place said, "This is what you got to do." He said, "I'm a doctor, but what do I do?" And he says, "Those 4 people, I want you to go wash their feet." He said, "I'm a doctor." He says, "You can't be a good doctor unless you can communicate to these people. They don't know you, they don't trust you, they'll never talk to you. You'll never understand what their problems are. But by the time you're through washing their feet, you're going to be buddies. They're going to open up. They're going to tell you everything you want to know." He went on to become a wonderful, innovative guy, Jim O'Connell. I put Bob Masters right in that same category, and I am delighted to have him with us tonight, and hopefully you'll enjoy it. David, you go ahead and introduce people. Thank you.
I want to add my thanks to Charlie for sponsoring this series. It's been a delight for us, and one of the things that Charlie wanted to make sure we did was to create opportunities for alumni of the school to meet each other and to hear about important and contemporary developments in healthcare in our community. But it is an intended purpose for you to be able to spend time with each other as well. And so that's why we start with a little booze and we finish with something sweet that is certainly not in the public health interest. But should give you an opportunity to chat with each other. So I thank you all for coming and hope that you find this to be an interesting and useful evening in all of us. And I want to thank very much Bob and Christine for coming as well. You have at least brief biographic information about each of them. It doesn't do them justice, but we have 35 minutes, and I could use up to 35 minutes talking about each of them. I would just say by way of confession that Bob and I go further back to black and white television than is really appropriate to talk about in public. If you are all tired of having me around, it's his fault because he recruited me to the Dean School of Public Health when he was chairman of what was then known as the Health Services Department. And Christine was the beneficiary of those days as a graduate. So this is an important night for the School of Public Health to brag about its graduates. So I thank you both very much for coming. And the title of the evening is Innovators in Healthcare. So what do you innovate? What do you do? Seriously, give us just a couple of minutes on the most recent piece of creativity that should be the common basis for the discussion.
I would like to ask Christine to start. I'm still reeling from Charlie's eulogy here.
But it is so nice to hear.
Yeah.
Sure, I can start. So, let's see, in the last 15 years, I've primarily been at two places, a Medicaid health plan for many, many years, Network Health, which is now Tufts Health Plan, and then at a kind of sort of basically startup, so-called ACO, Accountable Care Organization, that was started with the Beth Israel Deaconess Medical Center and their physician partners, originally organized in a physician organization. And they decided that they wanted to become a new entity and so-called Accountable Care Organization. So they sort of wrote it down, all down on paper, and this is what the governance model looks like, and this is how we'll create a financial system of risk and reward to do a better job in managing for in any given year set of patients a budget to decrease, to improve our experience against historic costs and to improve quality indicators. And so a lot of people, I think people don't say it anymore, but people used to say, I don't know, Bob, if you heard this, but ACOs are like unicorns. You hear a lot about them, but I've never seen one. I'm not getting that exactly right, but it was something like that. And I'm not sure people are saying it anymore because now there's a lot of different ACOs. And I think now the story with ACOs is similar to what people say about community health centers, which is if you see one community health center, you see one community health center. It's probably true about ACOs. If you see one ACO, you see one ACO. So now I'm forgetting what your original question was. But
You're answering.
So I would say that was very, very innovative, both in terms of things that were written down on pieces of paper on how the business would work that hadn't been tested in real life. And so we tested them. They're actually living the experience of it. And some things worked and some things didn't work. And then we grew like crazy. When we started, we had one hospital in our accountable care organization, and we blinked our eyes. We had 7 hospitals, and we blinked our eyes when we were managing well north of $1 billion in total, so what is called, total medical expense risk revenue for all of those patients, members who were part of our ACO, the aggregation of all of their budgets. So it was, that was about over an 18-month period. So it was pretty wild. I'm happy to talk more about that, but I don't want to ramble on.
I'll come back to it.
Pass it over to Bob.
Well, let me take the prerogative of not starting what I've done recently, because it really goes back to athletics. And it goes, I personally have not had a relationship with America, but through it, except you. But so maybe I'll start my story back, and David knows this very well. I became a physician and trained at Boston, the old Boston City Hospital, which was the wellspring for the first generation of community health centers. And I went after training to go out to a community health center where we worked at the Lennox. And I was for $16 an hour, by the way. And I did about $17,000 a year. And we and a whole bunch of colleagues were going to right all the wrongs of the inequities of the healthcare system, and that was the time. It was the 60s and the 70s, and ran right into the wall of the power of the academic medical center, and particularly the academic medical center.
That how it's running.
Well, that was the city, but it was actually, I want to say, the university and its distortions of where the values were. But the question was, and so the best way I could describe it, I think, to begin, was really an iconic influence in me, Jack Geiger, who also years earlier trained at the old Boston City, and was the father of the community health center movement in the 60s and OEO. And he said, trying to implement the principles of real primary care and population-based care in Boston City Hospital or any academic medical center is trying to implement the principles of forestry in a lumberyard. It is absolutely, the contradictions are way too great. There are too many beasts to be fed before you really get to the question. And that I hit right away. Simple things, and David was there at the time, and this was not, David, it was an ally, but these were the academic structures. We couldn't eat simple little things and say, wait a minute, we want to take care of our own patients in this hospital. We've been trained here, you want us to be faculty here, but we can't. The patients were, quote, teaching material. And the equity of continuity of care didn't exist. And by the way, it didn't exist anywhere it wasn't just, I'm not single out Boston. You had separate floors. It was a medical care apartheid. At Mass General, at Brigham, at Boston Medical Center, so that, Boston City, that was the rule. And the real question was, what does this do to people that are sick, vulnerable, and as I came to learn later, it's very, very expensive. And it really didn't matter whether somebody was, there was an aphorism. This was low-income communities, the poorer one gets, the sicker one gets, the sicker one gets, the poorer one gets. And that was the world we were in. And so what is a rational care system that can change that equation and actually put people first, get what is a system, what does the delivery system look like that actually can promote autonomy, independence, deal with complex chronic illness and disability, and actually have the hospital work for that vision as opposed to having the vision being part of the hospital. It was the other, and I'm stopping right after this kind of paradigm. Was it a Ptolemaic universe or a Copernican universe? A Ptolemaic universe was the hospital as the center, and everything and the academic revolves around it. The Copernican universe is no, the person's the center, the community's the center. And the hospital should be revolving around that. And I think what I hit and others hit at the time that was the wellspring for so much of this innovation was we were having a Ptolemaic universe, and that had to be changed.
So tell us, flash forward to CCA Lab, because the Commonwealth Care Alliance and the ACA that Christina just mentioned are both part of the ACA experiment. You know, the ACA was about Medicaid, blah, 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 but it's also about huge experimentation. So say a word about CCA, and then what I really want both of you to say is whether you think how these experiments are.
Well, I've got a bunch of scars. Should I go ahead and show So CCA's story begins earlier in the 1980s, and actually it begins with a collaboration with David and I. So this is our story. The precursor to CCA was a small-scale innovation that said, for the sickest, most complicated Medicaid beneficiaries, people with HIV/AIDS, people with involved physical, developmental, and mental illness-related disabilities, what works? And a small entity contracted with Medicaid, which we call the Community Medical Alliance, really was created, and David was, we were part of that to create that, and that was 26 years ago. And it was taking on the biggest single problems of people on Medicaid. And at that time, it was HIV/AIDS was moving rapidly to Medicaid. And Medicaid was the place by default where people with really involved chronic illness, disabilities, found their way to. And the service didn't work, typical managed care iterations didn't work. What did work? And that was the first wellspring of innovation. And global payment, we use the word risk adjustment, but in fact it was much cruder then, but we had a forward-looking Medicaid director, Bruce Bullen, that wanted to experiment, and that's critical. I have to tell you, the opportunity to be innovation on policy and from government is extraordinary. And it's sometimes sad how rare that is. In this case, it wasn't. And what was developed were premium rates for people with involved HIV and AIDS and people with involved disabilities. And unlike going to an insurance entity, it went to a clinical entity programs. And it was new principles, interdisciplinary care teams, shifting care out of hospitals and into home, the ability to create a hospital at home, having the dollars to do all of that, and incentives. And what did that do? And that was the beginning of what later was to become Commonwealth Care Alliance. And what we demonstrated there was that you could dramatically improve care, reduce costs, improve autonomy, keep people home, and particularly HIV and AIDS at that time, which was a horrific illness and needed a blend of palliative care and home care, could be elaborated for people in accordance with their wishes in ways that previously weren't there. And it seemed to meet all the checkoff boxes. And the question after that was, how do you scale it? This is really lovely, there's a lot of things, but we've got a few hundred or 1,000 people and $20 or $30 million of premium. That doesn't work in the real world. And so I'll stop there, but David and I were partners in that effort that led a few years later to Commonwealth Care Alliance.
Christina, are these experiments working so far?
I think that it is too early to say. I think there's reasons to be optimistic when you look at the federal evaluation that went on of the Pioneer ACO program. You could be wowed by those results in terms of money saved. I think that there is reason to be fearful. And getting back to something that Bob said, when you were talking about your experience in Boston City, and I worked there too. And thinking about what you said on what happened with sort of what I call kind of, the Pac-Man, the pack person dog sound, and the feed the beast mentality that goes on at a hospital. You looked at, and then the community health centers and how that brought care into the community. And we've come so far since then, but it's almost like fear, looking at this fearfully, that you could say it's almost coming into a circle. And if you look at the amount of primary care that's been acquired by hospital-based systems, and then you counted in the number of community health centers that are either now on a hospital's license or part of a hospital-based ACO system, and you counted up all of the increase over time in services rendered by a hospital, and you looked at that financial equation against where the healthcare dollar is spent in a facility against your experience at Boston City Hospital against what is happening today, I think probably it's starting to shift more toward what it was back then. And I think that that's a reason to be fearful, is that, and if you look at the early successes and where, if you were to ask me sort of based on the early successes, where do I think there's hope, where the sort of the big pain point's going to get to a real breakthrough transformation of quality improvement and serious cost management, it's back to, it's kind of easy to squeeze the end of the healthcare system and get patients not into a post-acute bed, but get them home instead, and do some stuff around the perimeter, trim some stuff out of hospital. But when you really start getting in there, and it starts to be, an anesthesiologist's job, a radiologist's job, an ER doc's job, that's sort of, that's a different conversation, and that's a different ballgame, and that's the conversation that's going to have to happen, and what's going to have to actually be effectuated if we're going to sort of get that real hunk of what I believe is waste out of the healthcare system.
So that sort of brings me to a question that I wanted to ask. You've both been terrific innovators, and you're saying there's some fearful things on the horizon that may recenter things around the hospital. What makes the innovation sustainable? Most of the innovations that we really see don't last very long. I was in a meeting a few months ago with the president of the MGH who said, well, we have our good centuries, we have our bad centuries. How are you gonna, what do you think are the challenge, not so much the challenges to sustainability, but the sort of magic that you think is going to need to happen?
I'll say, what I became convinced of over the years was that, first of all, you have to do it at scale. And it has to be big enough and have an impact sufficiently that the vagaries of all the power relationships and avarice and greed out there can't take you out. And that's the problem with most innovations. They're small scale. They often demonstrate very promising things, and they're value tied, but it doesn't register. And we who have been in government know that. I mean, you have only so much bandwidth to deal with so many different innovations, and so that's the first thing. The second thing, I think it really has to demonstrate in healthcare what Don Berwick is called, the triple aim. In that it's all tied together. You really have to improve quality and cost and the individual experience of individuals and family. That's 2. And 3, you have to do it in a far more effective way, cost effective. If you do that and you have the policy structures for that, and I really believe the ACA was a major step forward in that, moving to global. Now we have a language now. We never had this language before. Global payments, risk adjustment, far from perfect, but at least it's there and it's moving. Redesign elements of primary care that aren't tied to a treadmill. Your productivity is not the currency. It's really outcomes of what happens and satisfaction. So interdisciplinary teams, individualized care plans around what people need for service packages. These are all things that needed to be tested at scale. And I think if you do that, and you develop a political constituency that says, I need this, and I don't want to go back without it, that is the way you have the best shot of sustainability. And that's essentially been the challenge that I've been engaged in the last 12 years, to try to bring some of this to scale.
Scale. Christina?
But I guess to think about a different angle on your question, I think that, so let's call whatever that future, like the revolution happens, right? The healthcare revolution really comes. Sort of how does that happen and
What does it look like?
And what does it look like? How does it happen? And I think it happens, I think it's got to be from the people, right? One of the ways that healthcare has been really working is that the individual consumer is completely disintermediated from cost of care. Now, there's been some incremental change and improvement and a whole lot of effort to try to get to that disintermediate place. Huge aspects of the ACA, what Massachusetts started with the connector, now with the exchanges. Other tools insurance companies use, like deductibles and co-premiums and limited networks and tiered and all of this. But although there have been pockets of success, at the aggregate level, it has largely, I would argue, been unsuccessful. And I think that one of the problems is that there's a lack of a shared cultural societal value on the price of healthcare. So if you look at where all of us were around global warming, climate change, and what did we think was a problem, and did we think we as individuals or families or communities could do something about it?
Yeah.
Okay, so first we began to believe it was a problem. And then we all believed that the individual things that we did mattered to us, that we were part of trying to make the planet better. And it mattered if we walked on the road and turned off the light switch or used a reusable bag. I think you can take that analogy into healthcare, where I think everybody at this point would say, do you think healthcare costs are a problem? Yeah. But am I going to change my purchasing decision? Even if it doesn't affect me, because my employer isn't going to change my price point if I get care at Boston Medical Center or at Mass General. But am I going to decide to get it in a lower cost setting because I care? And that's an example, but I don't think it's till we get to that place as individuals and as a society that we're not going to see a revolution of change in healthcare costs.
So, you've both been great innovators. And one of the questions that I always had when I watched Bob was whether mere mortals could do this. So, a little bit of reflection, but what makes somebody an innovator? What are the either the personal characteristics or the opportunities or the atmosphere or the environment or what mixture do you think makes it possible to actually be in?
Well, by the way, it's an honor to be called a social entrepreneur. Charlie actually probably pioneered that term early on, and I think it's passion. You know, it's a spiritual quest. It's a spiritual quest, and so maybe it's a secular form of religion. You know? But seriously, why are we here? There's got to be a belief that you and working with others can make things better. If you don't believe that, then it speaks to what you're talking about. And by the way, thank you for the analogy talking about climate change, which I actually believe is the challenge of our the 21st century. And people are believing they can change. It seemed overwhelming for a while. I think we're going to see things in Paris next month that are going to be inspiring as opposed to what we saw last week. But because of that, so I don't want to digress too much, but there is a belief that we can do something about this, and individuals can. And when one does it, you find others, and you find others, and I would say in our situation, it was really a confluence of people with all different skill sets, both from management, analytics. I want to say nursing, particularly. I mean, let me tell you the degree of education that we had, physicians needed to unlearn. And if they would just listen to nursing colleagues, you were on a path to innovation that it's hard to return from at that way. So it's a belief that it can be better. You're driven to it. The value of life. What makes life worth living is taking on meaningful challenges, and sometimes failing. I mean, you gotta get beat up and fall down and pick up and keep going. And that's why, you know, when you do that, and people that are driven like that, I think, have very enriched lives. Although there are many days it doesn't feel so good. And so it's in touch with that. And not being alone, finding your voice with many others, and being a part of something much larger than just yourself. Christina?
Great answer. A very healthy fear, acceptance of repeated failure.
You haven't made it until you failed. We failed a few times.
Over and over and over, and really be a risk taker and fail repeatedly. When I was a kid, my father is an artist, he paints, and he's an architect, and I have two brothers. One is an animator, one a photographer. My uncles and aunts are artists, and I did not get the art sheet. And so I felt very inadequate my entire childhood. And I think part of why I'm an innovator is because I like ideas, and I like creativity, and I like sort of, testing that creativity and tinkering and failing and moving on and doing it again. And I think another thing that Bob and I both share is we've chosen to innovate in a pretty specific space, which is vulnerable populations and underserved populations. And I think it's also, working with that population, understanding what poverty looks like and what those people's lives are like, and feeling compelled to try over and over again to try to break through this system, which really perpetuates a lot of the reasons why people are living in poverty in the first place, and try to cause some disruption to hopefully have a meaningful impact on those communities.
Good. So I asked before we sat down whether either of them had a softball question that they wanted me to ask them, and then stared at me blankly. So what we're going to do is let you ask softball questions. We have microphones spread out someplace, and let me encourage you to ask questions of Christina.
All right, and this should be a softball question, Christina.
They don't have to be
Sports.
So under the ACA, prior to the ACA, ACA, you were one of the first health plans to come into the connector, which became the prototype for all the exchanges. So what did you learn converting from being just strictly Medicaid managed care to serving a population that kind of moved a little bit up the income scale? And it's just interesting for you to reflect on that a bit because you were among the first.
Yeah, I mean, I think specifically to sort of aha moments or lessons learned about the differences in serving to the different demographic of those populations is that I would say most of the demographics and characteristics were more similar than different. And in examining the pockets where they were different, probably a higher level of, when you get up to the higher income of who we were serving, a higher level of engagement, I would say, which is, you've worked a lot with the populations that are at 133% of the federal poverty line and under. There are a lot of good reasons for barriers to effective engagement. So we were sort of dealing for the first time with people who were graduate students, and had different expectations from us as a health plan. Different expectations of access to care, and so it was changing a lot of, I would say, mostly sort of unsexy internal operations, different stuff in our communication style and our branding style to be more effective to that. And I would say it was less about, and partly it was because of how the Commonwealth Care program was structured. It was less about people complaining about deductibles or the network, or it was less of that stuff. Although, I think in year 2 of the Commonwealth Care experiment, we did go to a limited network. And we were the first health plan in Massachusetts to go to what was a real limited network strategy. And it was surprisingly successful in terms of member satisfaction remaining very high and being a great strategy in keeping our prices the lowest of any plan in Massachusetts.
Hi, Bob. Those of you who don't know, Bob also started the Medicaid Working Group, which had become a Health and Disability Working Group at the Boston University School of Public Health, where I currently work. So I really appreciated your remarks, and your passion is still evident. So now here's my question, which is not really a softball question. now that I was nice to you for a minute, that's all. So the whole issue of bringing projects to scale is something that we have struggled with over the years. And I think it's related to return on investment. So you work and work and work and work, you bring care management, you get folks' care plans under control, you're delivering services in an efficient way. And then the next year the benefit plan changes, or the state budget crisis hits. And so in some ways, I feel like I could have been asleep for 20 years and woken up, and I still feel, even though these are innovative, it's still a little bit of the same conversation, which is the point that you made, Christina. So how do we change the view of policymakers and purchasers so that it's more than 1 year budget cycles?
Yeah. Well, so that's a tough one. Let me give you my experience. I don't know fully answer. I'm not certified for all this technology. So I'll give you just our experience, and others can determine whether this is an answer to you. So we took off. So Commonwealth Care Alliance went statewide. We contracted with Medicare and Medicaid, and risk adjustment. We had our senior program, smaller, younger age, 65 program. A cornerstone of the ACA was saying, Massachusetts, you're the lead demonstration, and we ended up as it turned out, the lead contractor in this demonstration. And we were, for the first time, taking populations in that never had been brought into a coordinated, comprehensive care system. People with serious mental illness, concurrent substance abuse, intermittent homelessness, Hep C, and I won't even go to the pain for the new Hep C medications and interventions, and where there was little or no trust, and for very good reasons, of the healthcare system, little or no meaningful engagement in the healthcare system, and quite frankly, little or no comprehensive experience to give Medicare and Medicaid, and particularly Medicare, CMS, a basis for accurate risk-adjusted payments. And we I don't know if you've seen our ads on the buses and TV and radio all everywhere, but it said in one word, people with involved disabilities, cognitive, mental illness, physical, developmental, welcome here. And they came, and by the thousands. And within but within a year and a half, we were totally awash and ready, not even close. And there seemed to be something just totally amiss in terms of core financing policy, because we were the canary in the mine shaft with 10,000 people and $400 million of premium on just this population, and sliding down the tube. And what happened there was we also became, we became really the as I said, the canary in the mine shaft that identified for the first time not only what some of the care delivery challenges were, but what were the policies that were lacking. And what came out of it was either Commonwealth Care Alliance is going to go down, and 17,000 people are going to lose all of this after years and years and years of this work, or there's going to be not a bailout, here's some money to deal with it, but some fundamental fix in things like risk adjustment, both on the Medicaid side, the state, and Medicare side, and other things. And that fix came in 3 increments over a year and a half. First, in 2014, it came to about $22 million. And just about 3 months ago, when we were getting very, very close to breaking through regulatory reserve requirements, approximately at over 15 and 16, about $50 million of that's a lot of zeros. Let me tell you, this is. But these are not just for us, but essentially writing the underpinning payment. And so, the answer is you've got to go to the edge of the cliff and look down into the abyss and say, do you really want us to crash and burn? Or not. And at least in our circumstance, it's a pleasure to report, and I feel like we're a public utility that is a part of the ACA and its demonstration, that we had our policymakers in the federal government and the state come through not with some fundamental change, not only for us, but for anybody else going forward in the other demonstration states. And so that's a different story, Sally, than, well, we keep running into it, and believe me, we do every year. Stateless shortfalls of $10 million of scope premium disappear, and that happens all the time. That's the baseline. But we experienced it was an existential crisis, and a few months ago came through it, and it wasn't at all certain. So that's another side to the story. If you can demonstrate. And it may not have worked. I mean, we had, and I can see that we could have a wonderful rest in peace gravestone. It's a great effort. But in this case, at least, and whether whether that's the antidote to what you're talking about, it's a more generalized sense. I can't say. That's just been our experience.
So going back to what you said earlier, you just became too big to fail.
That's an AIG.
Christine, do you want to respond to what Sally is?
Yeah, I mean, I think, and this is kind of a public health view, is that for such a progressive state that we live in, there really hasn't been a lot of conversation and no action in adopting the one common set of quality measures for younger people, adolescents, adults, older adults, that are also, so that we get doctors and hospitals and health plans focused on the same thing. And furthermore, thinking about what those might be that go beyond a medical model. And the example that I like to use as a health indicator, because we know that is kids reading at level at age 5, right? Because we know that kids who aren't reading at level at age 5 are much more likely to have an adverse health event or health status as an adult. And I think that if we got to a place where we had common, regional, or statewide health or public health measures, that it would help us keep the focus longitudinally and throughout the Commonwealth, even when things like Medicaid churn happen and other disruptions happen underneath, that there's still one single incentivized focus.
Okay.
Bob, can you tell us what some of the policy changes were that produced the results you're talking about?
If you wake me up at 3 in the morning and say, "Rip, set them up," I can do it in an instant. The first thing was Medicare risk adjustment. It's a diagnostic system, did not fully account for the real costs, and there's a social determinants to account for it. But even poverty, the dual status as a surrogate, as an indicator of poverty, was not adequately adjusted. And there's a battle royal right now, and I'll explain that research showed that those of us who were caring for this dual impoverished Medicare beneficiary population were being underpaid by a range of 5 to 7%, depending on the different clinical groups. That's even before the risk adjustment. And Medicare Advantage, that was caring for the more middle class, people that could hike up Mount Washington and maybe had a craggy knee or something like that, were being overpaid by somewhere in the range of 2, 3, 4%. And it's a zero-sum game in Washington. So the demonstration authority was used to take the demonstration and say, we will pay you this retroactive. And that's huge, 5, 6% of Medicare premium. And that's fundamental fix. Now, and a call letter, if people know how Medicare works, call letter went out announcing that this is where Medicare is going. They're going to rebalance. Now, and what that rebalance means is hundreds and hundreds of millions of dollars essentially shifting from one plan to plans dealing with the populations that we have. And the fight is now joined because, so we have it, but in fact, that was a courageous move in terms of our leadership in Washington to basically use demonstration authority as to give us the retroactive increase and then announce that this is where Medicare is going. It's easy enough to do that, but the real issue is, remember, it's zero sum. If we're going to get, and everybody else in this space is going to get that extra 6, 7%, they're going to be losers. And we know who they are, and we know how many lobbyists they have, and we know the power, and it's already underway. And that battle is now joined for a policy change that would be announced this spring of 16 to be implemented January 1, 2017. So that's the biggest one. And there were a lot of smaller pieces, but I really, I think very proud to say we were in the middle of that, and without this moving it forward to make it full Medicare policy and this readjustment, there was no basis for giving us retroactivity as a demonstration. So a lot of guts and a lot of change in our government. This example.
One more question.
So before I got here today, there's a news in the financial world that may have impact on what we're talking here today, which is United Health made an announcement today that they may exit the exchange by 2015 because of the fear that they're not going to make any money or take a loss on the company. So what are your comments on that, and what's the long-term impact on ACA?
Honestly, without knowing what kind of market share they have nationally on the exchange, which I don't know.
36.
6?
36.
36, really? They have 36%.
Yeah, 36 exchange right now.
Okay, so that's assuming that those numbers are right, that's downside would be that's pretty damaging. The upside would be, opens up a lot of opportunity for smaller plans to potentially have the opportunity to bring better products, more consumer responsive products to market. But I, not being an expert on those states where United has high penetration,
Yeah. Without knowing the specifics of that, we could never have done what we've done if we were part of a publicly traded entity that really has to bring that bottom. I mean, at the end of the day, the fiduciary responsibility is to bring that bottom. They're acting in the way they're supposed to act. If your primary goal is innovation, if your primary goal is transformation and being part of as a social entrepreneur, you are willing to take that, you're alive to take on those risks, and so it's a different context.
I have one.
One more question? Sorry. My question is, how are you gonna approach to fix the issue for population who fall on middle class? Like deductions, co-pays, things that we can afford to do. Thank you.
Were you here when I talked about the revolution? Gonna get you in it. I mean, you know, we all agree that there are profound economic problems in this country, including erosion of the middle class and the continued escalation of healthcare costs. I think I agree with your theses, with the exception of private practices opening. Private practices are becoming almost extinct because of the rapid acquisition of community-based practices by larger systems. And primary care docs do complain a lot about EHRs. I don't know, Bob. They used to complain about their paperwork. I'm sure, you know, I'm married to a family doctor who works wicked hard. You know, if you look at primary care salaries, they have come up in recent years, so that is a positive indicator of some redistribution. Some of that, of their salaries coming up, is because they are a commodity now, and when they're bought by a larger system, it gives them the opportunity to increase their economics. I don't think that, I don't want to speak for you, Bob, I'm going to, so you know, I don't think we have an answer or a solve to your particular question, other than saying, I think we both would absolutely agree that the healthcare system, although there have been innovations, and particularly around United, remains profoundly broken.
Yeah. And I guess the only thing I would add, that's a huge, what are we going to do about the nitrogen cycle here? So, but what I would, I'd say this, and the pain of the shrinking middle class and wage stagnation and all of that is real. I think Bernie Sanders has tapped into something here without question. But if you really look at the last 30, 40 years where this has happened, what's been a major contributor to wage stagnation, and that's been healthcare costs. Employers having to feed that beast, that have essentially constrained wages. And there's everywhere, and for working class and other people. And of course unions that were a buffer to that have lost a lot of their power in the last 20, 30 years, some of it justifiable. And so those two things are real. So to the extent that we have to get healthcare costs down to GDP, and our own state has finally done that for the first time. Our own state has said, well, trying to do it. No, look, chapter 220, yeah, I mean, legislated. Well, all right, let me step back. But even the legislation is a sign of intent. And the second thing, the last thing, the other important thing that happened in the very first part of this year is Maura Healey said enough to the largest healthcare system in Massachusetts that was distorting the cost of healthcare for everywhere, and was directly, we are now politically requiring people to get health insurance and pay all the co-pays and the deductibles and do all of that. And people are starting to wake up and say, wait a minute, if you're distorting all the costs so high, I mean, it's coming out of my pocket, poor working stiff, to go to Mass General, and you gotta name it. And Maura did that. And so things like that are starting to happen. I guess I would be optimist, that's all.
This actually might be a good place to close with a challenge for future discussions, because, you know, the School of Public Health has an absolutely appropriate mission to focus on the needs of vulnerable populations. And our commitment to ethics and equity drive an enormous amount of what we do. But the reality is, with respect to healthcare and the economic structure of the large portion of the population in the United States, is that healthcare costs have shifted badly to them and affected their incomes, quality of life, and in fact are a challenge in public health in ways that I think we need to pay more attention to over time. So let me thank Bob and Christine for coming.